For decades, clinical medicine relied on a simple numerical threshold to dictate obesity management. We now know that isolated weight measurements and a baseline body mass index are inadequate triggers for medical intervention. Modern clinical standards dictate treatment thresholds based exclusively on the presence and severity of adiposity-related complications. This chart maps that evolution. A baseline physical measurement, like BMI, sits at the center, but true physiological risk is only captured when we extend axes outward for specific comorbidities. Factors like HbA1c elevation, refractory hypertension, and long-term cardiovascular risk. To construct the contemporary treatment algorithm, we have to evaluate the specific efficacies and trial data of every available intervention, from initial lifestyle adjustments through pharmacotherapy and bariatric surgery. Before any clinical protocol begins, the therapeutic vocabulary must be addressed. Patients prefer neutral terminology, such as excess weight or simply discussing BMI. Stigmatizing terms like morbid obesity generate clinical resistance and compromise the therapeutic alliance. Establishing precise, unbiased language and accurate morbidity profiling forms the mandatory foundation. Only when those two prerequisites are met can a clinician safely begin interventions. The clinical evaluation phase opens with a stringent audit of the patient's existing medication profile. The goal is to identify and isolate secondary, iatrogenic triggers for weight gain. This checklist isolates drug-induced weight gain using the ACED mnemonic: antipsychotics, steroids, sulfonylureas, antidepressants, and antiepileptics. Pay attention to clozapine and olanzapine for high metabolic risk. Also differentiate true adipose gain from peripheral edema caused by NSAIDs and calcium channel blockers. Once pharmacological variables are isolated, the focus shifts to disease staging. Systems like the American Association of Clinical Endocrinology Criteria and the Edmonton Obesity Staging System provide the framework for quantifying disease severity. The Edmonton system is particularly rigorous because it categorizes patients based on distinct medical, functional, and psychological domains. It operates entirely independent of the patient's BMI value. Combining a rigorous pharmacological audit with a complication-based staging system prevents two critical errors: mistreating fluid retention as adipose gain and overtreating patients whose high BMI is strictly asymptomatic. Regardless of the patient's starting metrics, the initial universal threshold for treatment is targeted and precise, achieving an 8 to 10% reduction in total body weight over a 6-month period. This waterfall chart graphs standard intervention efficacy. Lifestyle management alone yields a modest 3 to 5 kilogram loss. For rapid intervention, clinicians escalate to very low-calorie diets, capped at 800 kilocalories daily, prioritizing protein to preserve lean muscle mass. The efficacy of this strict caloric limit was proven in the landmark DIRECT trial. Following this formula diet for 3 months induced roughly 50% type 2 diabetes remission at the 12-month mark, allowing patients to discontinue all anti-diabetic drugs. Standard diet therapy relies on two mechanics. Total caloric deficit is the absolute requirement that drives tissue loss. However, manipulating food energy density, choosing high-volume, low-calorie foods, maintains physical volume in the stomach to suppress the mechanical hunger response. The clinical role of physical activity is highly specific. While 300 minutes of moderate exercise a week is mandatory for maintaining weight loss over time, it is highly inefficient for initiating that reduction. Lifestyle modifications set the patient's metabolic baseline, yet they possess a strict biological ceiling. When patients present with severe comorbidities, that ceiling necessitates immediate pharmacological escalation. Pharmacological intervention relies heavily on neuroendocrine manipulation. These drugs hijacked endogenous neural pathways to force sustained appetite suppression. On the POMC neural pathway, bupropion attaches, stimulating an alpha-MSH signal to reduce food intake. However, a secondary loop releases beta-endorphins that block this effect. Administering naltrexone severs this opioid feedback loop entirely, allowing prolonged appetite suppression. Other combinations, like phentermine and topiramate, operate on separate neurotransmitters, but carry strict clinical warnings. Because topiramate is teratogenic, clinicians are mandated to enforce monthly pregnancy testing to mitigate the risk of oral cleft malformations. When plotting the clinical yields of these agents, including peripheral lipase inhibitors like orlistat, the data is consistent. Placebo-subtracted weight loss plateaus in a tight range between 4% and 9% over 1 year. Early pharmacotherapy proved the viability of manipulating neural pathways. However, single and early dual receptor targets hit a distinct biological efficacy ceiling. They provided a medical option, but their yield failed to rival the physical reduction achieved by surgery. The gap between oral medical management and surgical intervention was finally bridged by the development of GLP-1 receptor agonists and subsequent dual agonist incretins. Returning to the efficacy chart, the y-axis must scale up dramatically to map the outcomes from the STEP and SURMOUNT clinical trials. Semaglutide pushed the ceiling to 14.8% weight loss, and tirzepatide elevated it further to 21.4%. This leap in efficacy tracks the structural upgrade from first to second-generation agents. The daily dosing of single GLP-1 agonists evolved into weekly injections, followed by the engineering of dual GLP-1 and GIP receptor agonists that exert a synergistic metabolic effect. This clinical data card outlines parameters of the SELECT trial, a study shifting clinical focus from weight loss mass to primary cardiovascular outcomes. The SELECT trial results show that 2.4 milligrams of semaglutide reduces major adverse cardiovascular events by 20%. Crucially, this benefit was observed in patients with pre-existing cardiovascular disease and obesity who do not have diabetes. Despite their efficacy, all incretin-based therapies carry a strict universal class contraindication. They cannot be prescribed to patients with a personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome. High-dose incretins now function as frontline cardiovascular risk reduction agents. They provide medical utility that addresses the underlying drivers of major adverse cardiac events in non-diabetic populations. At the absolute apex of the efficacy hierarchy sits bariatric surgery, yielding an average of roughly 30% total body weight reduction. The gatekeeping thresholds for surgical qualification are non-negotiable. Patients universally qualify at a BMI of 40. For patients with a BMI of 35, surgery is indicated if obesity-related comorbidities are already present. This split-screen anatomical diagram compares distinct mechanical approaches. On the left, restrictive-only procedures like laparoscopic sleeve gastrectomy reduce gastric volume. On the right, restrictive malabsorptive procedures like Roux-en-Y gastric bypass reroute the intestinal tract to limit nutrient absorption. Older restrictive methods like gastric banding are now nearly abandoned. However, malabsorption from the Roux-en-Y bypass creates inevitable micronutrient deficiencies. Clinicians track lifelong supplementation using the BIFCAD mnemonic: B12, iron, folate, calcium, vitamin A, and vitamin D. The postoperative impact on systemic disease is complex. While surgery drives an impressive 68% initial remission rate for type 2 diabetes, longitudinal data shows that 1/3 of those patients will relapse within 5 years. Surgery offers maximum immediate weight reduction. The biological trade-off is that it effectively swaps the systemic disease of obesity for the chronic, lifelong management of engineered malabsorption. Analyzing these individual efficacy tiers in isolation is useless without a central protocol governing exactly when a clinician should escalate care. This matrix cross-references a patient's physical mass on the y-axis against systemic disease on the x-axis. The first clinical pivot is here. At a BMI of 27 to 29.9, pharmacotherapy is withheld unless an obesity-related disease justifies the intervention. Universal pharmacological intervention arrives at a BMI of 30, triggering medication eligibility regardless of comorbidity status. The surgical gatekeeping mechanism is equally strict. At a BMI of 35, bariatric surgery is only triggered if accompanied by severe complications. Finally, a BMI of 40 or above universally qualifies a patient for bariatric surgery, overriding the need for pre-existing comorbidities. The modern clinician does not treat a solitary number on a scale. They navigate this continuous spectrum of interventions, applying escalating mechanical and pharmacological pressure to dismantle specific adiposity-driven pathologies.